Hello, everyone, and welcome to the physician-led webinar on COVID-19 and intravascular volume management strategies in the critically ill. CHF Solutions is honored to host this educational webinar in an effort to provide perspectives from world-renowned physicians in Italy and the United States regarding the importance of fluid stewardship in critically ill COVID-19 patients. All participants will be in listen-only mode. We encourage attendees to ask questions as they have them via the chat function on the right-hand side of your screen. Before sending a question, please be sure to change the recipient to all panelists to ensure we see your questions. Participants on this call are advised that the audio of this conference call is being broadcast live over the internet and is also being recorded for playback purposes. A recorded version of this webinar will be available at www.chf-solutions.com. These are our forward-looking statements and additional information about Aqueduct SmartFlow system, both of which are available on our website. These are our panelist disclosures. Today's webinar will be moderated by Dr. Ravindra Mehta. Dr. Mehta is a professor emeritus of medicine in the Division of Nephrology in the Department of Medicine at the University of California, San Diego, where he directs the UCSD Masters in Clinical Research Program and is the site PI for the NIH-funded UAB UCSD O'Brien Center for AKI Research. He is an internationally recognized expert in the field of acute kidney injury and CRRT. He chairs the annual International AKI and CRRT Conference in San Diego that is in its 25th year in 2020. He is a founding member of the Acute Dialysis Quality Initiative and the Acute Kidney Injury Network. His research has informed the development of the RIFLE and akin diagnostic and staging criteria for AKI and development of KDIGO guidelines for AKI. He has spearheaded several innovative multi-center studies, including the CRRT versus IHD study, the CARD network studies on AKI, the International Society of Nephrology AKI 0x25 project, and several studies supported through the UAB UCSD O'Brien Center that have provided new knowledge in the field. He has been recognized as one of the best doctors in San Diego and the U.S. for several years. In 2008, he was recognized by the American Nephrologists of Indian Origin, and in March 2009, he was elected as a fellow of the Royal College of Physicians in the UK. He received the ISN Bywaters Award for Lifetime Achievement in AKI in April 2011. He received his MBBS degree from the Government Medical School of Amritsar, India, and his MD and DM degrees from the Postgraduate Institute of Medical Education and Research in Chandigarh, India. He subsequently completed a nephrology fellowship at the University of Rochester in Rochester, New York, and obtained his boards in internal medicine and nephrology in 1986 and 1988, respectively. He has been on the faculty of San Diego since 1988. I would now like to turn the call over to Dr. Mehta, who will introduce the webinar panelists.
Thank you, William, and thank you for the opportunity for us to present this webinar to the audience. I'd like to introduce Dr. Peter McCullough. Dr. McCullough is the Professor of Medicine and Chair of Cardiology, Vice Chair at the Baylor University Medical Center and also Texas A&M. He has been a chief force in developing and building the whole concept of cardiorenal syndrome and bringing together the disciplines of cardiology along with nephrology to address a lot of problems. My second co-chair on this is Dr. Claudio Ronco, who is Professor of Medicine at the University of Padua and at St. Bartolo Hospital in Vicenza. He has been a huge force in developing the whole concept of critical care nephrology, building the whole area for acute kidney injury research and taking to a large forefront the development of new extracorporeal organ support technologies, including the Carpe Diem machine, which is a unique device for managing pediatric patients. So welcome to both Peter and Claudio. Thank you so much for joining us this morning. So,
well, thanks. It's great to be here.
Thank you. So maybe I will start first because we have been in a unique situation over the last 5 months with the pandemic. And I was commenting this to one of our colleagues earlier, this is probably the first and hopefully the last time in our lifetimes that we would be encountering a disease which we all look at simultaneously across the entire world. We've never previously had the opportunity to see the consequences of one disease with so many different facets. And so as a starting point, I'd like to ask Claudio that over the last 5.5 months as this disease has progressed, and Italy was at the forefront of this, what has been your experience with COVID-19? How have you encountered it in your hospital? So if you would give us a little bit of a background of your hospital, your situation in context, that would make it easier for the audience to understand what we've been encountering.
Well, thank you very much for having me in this webinar. First of all, I agree with Professor Mehta that we have faced a situation that was absolutely uncommon. However, we are a little bit used to think for the worst and get prepared. And in fact, when I heard what was going on in China, in spite the World Health Organization and other institutional agency did not recommend specific measure, starting very early, approximately February 1st, we encouraged our CAPD, APD, and hemodialysis patients to wear protective devices. The same we did for the personnel, and we implemented 2 specific algorithms for suspicious diagnosis of COVID-19, so that up to today we had 0 patients in hemodialysis and 0 patients in peritoneal dialysis infected by COVID-19. We have recommended on February 6th in Lancet Respiratory Medicine to get prepared, however, for the tsunami that people would have probably faced in the ICU. And this is a little bit what happened. Although we were not hit like Lombardy, which is a few miles away from here, we still experienced a large number of admissions to the hospital, intensive, especially infectious disease department, approximately 200 people. And I would say in the range of 20% of them required admission to the ICU for profound and severe respiratory problems. Out of them, approximately 40% developed AKI any stage, and approximately 10% require renal replacement therapies or other extracorporeal support techniques. We have been prepared over the years for a large program of renal replacement therapy support for the whole hospital. Our hospital is approximately 1,000 beds, and We have approximately 100 sites of ICU across the hospital. The main ICU was approximately 35 beds. So we treated approximately 20 patients with renal replacement therapy requirements, but we did not face specific shortage of machines or personnel as they did in other areas of the planet, including well-developed areas such as New York or others. I think that the most challenging aspect was the fact that our nurses had to be inside the COVID area with a protective device and special wet dress and masks. And this was causing extreme discomfort, of course. But confronting with patients who were really suffering, this was nothing. The last thing I would like to say is that we, from the beginning, saw the severe situation that some patients develop when they present high inflammatory states and cytokine release syndrome. And in this patient, we wanted to use extracorporeal therapies for which we had experience already matured in sepsis. And we were able to limit the evolution towards development of severe organ dysfunction and AKI in several patients. However, the evidence for this is somehow limited because we could not create a randomized controlled trial. At the same time, however, we have to say that the evidence that people are asking for these therapies is lacking also for drugs, including tocilizumab or hydroxychloroquine. Recently, this article showing the aspect related to dexamethasone, I think, is also questionable, but we will see. Certainly, we have faced journals of very high impact, somehow unprepared and willing to publish quickly data that sometimes were a little bit debatable or questionable. And in fact, at least Lancet retired some paper, and I think there is a need now to look at this emergency with a little more calm and multidisciplinary approach, as we recently did with our acute disease quality initiative group of consensus that will soon publish the resolutions of a large group of experts.
Thank you, Claudio. So, Peter, could you tell us a little bit about your experience in Texas?
Yeah, well, Texas, fortunately, unlike Italy or China or New York or Detroit, has had a very different epidemic curve with a relatively flat but prolonged curve over time. And we've published a couple important observations I want the audience to understand, is that we had published at our center that 85% of patients admitted to the hospital have no community testing. And then conversely, the vast majority of people who get testing in the community don't get hospitalized. So while people have tried to use the overall infection rate as a proxy for the pandemic, it's led to a false lead every single time. What really defines a case of COVID is somebody sick enough to be hospitalized. The community spread appears to be happening completely independent of the hospitalization curves. I think this is a very important point. Of those patients admitted to the hospital, our very first patient was a businessman. He came from New York on a plane, got very sick in the airport, came to our hospital, quickly needed ICU care, was intubated, and within 3 days, he developed what we call a type 5 cardiorenal syndrome, where he went into acute heart failure, acute renal failure, and shock and died. He died before really anything could be done outside of mechanical ventilation, pressors, and fluids. And so as we followed this story along, we had an understanding that the hospitalization is really occurring due to a cytokine storm and a microthromboembolic storm. And what's happening in the body is the virus is probably long gone. And so antivirals are likely to have little or no effect in the hospital. What we're finding out is that patients develop tremendous respiratory failure and desaturation that in part is related to the adult respiratory distress syndrome with an overlay of pulmonary microthrombi, which has been shown on autopsy studies from Italy. And then the other important observation is that patients develop acute kidney injury. And we were impressed by the paper published in May 13th of this year in Kidney International from a 13-center consortium out of New York that reported that 36% of hospitalized patients with COVID develop a stage of acute kidney injury. And of those who develop acute kidney injury, over half, it's stage or stage 2 or 3 acute kidney injury. And the acute kidney injury is characterized by oliguria, a rapid development of azotemia, as well as hematuria and proteinuria. And the idea here is that it may be a micro angiopathy, if you will, involving the kidneys. Like Dr. Ronco stated, we also were very aggressive in renal replacement therapy, forms of support. We've had one young patient on ECMO for over 45 days, and she ultimately survived and walked out of the hospital after a very dramatic case and recovery. So what we're finding is with high levels of support in hospitals like ours that aren't overwhelmed but have a steady census of patients, that we can make progress in this pandemic. Over 90% of the patients at our hospital are offered research therapies in development, and they're divided into antivirals, drugs that are immunomodulating drugs, and then drugs that are end organ protective, cytoprotective drugs. So that's basically a synopsis of where we are in Dallas at Baylor.
Thank you, Peter. Appreciate that. So I think what's most evident is that there are different manifestations, or at least recognition at different time points, and they're determined by local factors, access to care, what's happening. In California, in San Diego, we have a 500-bed, actually 500 or 600-bed hospital healthcare system with 2 hospitals with 2 different of ICU, with almost 112 ICU beds. And at any given point in time, including now, we have anywhere from 30 to 45 COVID-19 positive patients, and about 12 to 15 of them are on ventilators, and about 3 to 4 of them are requiring renal replacement. The AKI expense is anywhere from 15 to 20%, varying in stage. So, and when you look at the publications from New York, there have been ranges of acute kidney injury as high as 70%, and in other instances, they're as low as 5 to 6%. So there's wide variation. So what I would ask you as the next step is to say, to address the issue is, obviously, all of these patients are being handled with the best approaches available at each institution. But common to all of them is fluid management. And so one key question comes in, and I'll start with Peter, is you alluded to the type 5 cardiorenal syndrome. And I guess my question to you is, in your experience with COVID-19, and from what you have gleaned from the course of this disease over the last 5 months, what is the role of appropriate fluid management in these patients?
In brief, in the patients who develop the fulminant syndrome, they do require volume resuscitation as well as pressors to maintain blood pressure and perfusion for short-term survival. So the fluid requirements are substantial. The insensible losses are substantial. We've seen patients with tremendous amounts of free water and develop hypernatremia. So they really do require large amounts of fluid resuscitation. And then once we get into a stabilization phase, several days on the ventilator, we end up with a situation where the patient does have chronic volume overload, and some of it's intravascular, a lot of it's extravascular, and that's where the extracorporeal therapies come in. Patients, in many cases, become completely diuretic resistant.
So Peter, just to follow up on that a little bit more, there have been, at least initially, there was a concern that a significant component of the multi-organ dysfunction was related to primarily cardiac dysfunction, with even some evidence of direct myocardial involvement. Could you just briefly go over the pathophysiology, as you understand it, with respect to cardiovascular involvement in this case?
Well, it's first off, it's pretty clear that this virus and this viral infection and cytokine storm is a very high stress on the heart. So if there's any prior cardiovascular disease, prior coronary disease, left ventricular dysfunction, then clearly the patient's at a much higher risk of death. But we've had cases where the patient has no history of heart disease, the heart is ostensibly normal at baseline, and then patients do develop a cardiac part of this cardiorenal syndrome. And of interest, troponins are elevated, but not in an ischemic pattern. Patients have elevations in blood, B-type natriuretic peptide, but again, not in an ischemic pattern and not as high as we see in acute primary heart failure. And then very interestingly, the echo studies that exist suggest that the manifestation of cardiac injury is more likely to be right ventricular failure. So to me, that all indicates a degree of volume overload and failure of the heart on the basis of volume.
But given that you talked about the microthrombi and the fact that that these patients may have different perspectives, there is this concept being floated that there are two different phenotypes of respiratory involvement with the L and H phenotype, and the distinction between them appears to be the development of pulmonary hypertension. So are you thinking that the changes that you're alluding to on right ventricular strain or failure are a combination of the microthrombi, or is it all volume?
No, I think it's three things. I think volume plays a prominent role, but the three mechanisms by which the RV can begin to fail are volume overload, pressure overload, and cardiomyopathy. And it's probably all three things. The pressure overload certainly can be due to this pulmonary microthrombotic angiopathy that develops in pulmonary hypertension. The cardiomyopathy component certainly could be an immune attack affecting the heart. About 2/3 of the cells in the heart are not cardiomyocytes. They're forms of immune cells and satellite cells, and it wouldn't be a stretch to think that there is some direct cytokine adverse effect on myocardial function. And given pressure overload and volume overload in the right ventricle, we start to see right ventricular dilatation, a drop in right ventricular ejection fraction. And if that right ventricle cannot pump blood through the lungs, the systemic pressure is going to drop and the patient's going to get into this vicious cycle of hypotension.
Right. Claudio, just building on what Peter is saying, so it seems that the disease process has some evidence of systemic involvement, systemic inflammatory response, cardiac involvement, volume resuscitation is required, and yet may contribute to some of the deleterious effects. So given your experience with your patients and your prior knowledge with the cardiorenal syndrome, to what extent is the volume management a major feature of managing these patients?
Well, I think that, as you know, I'm a big fan of volume management in every patient. So these patients have been showing up with different characteristics, and I think that all of these characteristics make volume control and management extremely important. First of all, some patients are admitted to the ICU in a status of dehydration due to diarrhea or a condition sometimes of either superimposed sepsis or capillary leak syndrome due to excessive immunostimulation and hyperinflammation. These patients require volume administration, but some of these patients, in spite of receiving a significant amount of volume, did not respond adequately. And the reason for this may be one, myocardial dysfunction. Second, maybe a capillary leak syndrome that will not provide enough perfusion pressure in the organs, and in fact, the mean arterial pressure may remain quite low. You often may end up in this patient with a significant level of fluid overload that in turn may cause aggravate myocardial dysfunction, or may especially aggravate the decreased perfusion pressure in the kidney. As a matter of fact, congestion may be important in this situation. At this point, several of these patients who originally required fluid administration may actually require fluid removal. And not all of them respond adequately on administration of diuretics, especially for the reason that circulating blood volume may not be adequate, and the perfusion pressure in the kidney may not be sufficiently high. So some of these patients may resolve their situation with the administration of vasopressor support and noradrenaline as being utilized. But some of these patients require progressive and simultaneous removal of fluid overload. And in this patient, we must say the majority of patients developing AKI had as a primary indication for starting renal replacement therapy and extracorporeal ultrafiltration the level of fluid overload. This is something which is quite common also in general ICU patients, and we have made an analysis in the past, and almost 80% of the patients that start renal replacement therapy are patients that present as a primary indication fluid overload and fluid management requirement. Of course, in the moment you start this process and you prescribe your therapy, net ultrafiltration is and should be prescribed based on the overall fluid balance of the patient, and therefore the net ultrafiltration in the machine or the extracorporeal circuit not necessarily represent the net fluid loss in the patient. You have to match this with all the other fluid components of the balance, including input and outputs. In patients that are oliguric, actually, you only have to compensate for intestinal losses, insensible losses, and for losses due to mechanical ventilation. I must say that in a large majority of these patients, when you start to provide a negative fluid balance with a very slow continuous ultrafiltration, allowing progressive intravascular refilling and not affecting hemodynamic instability as you would probably with aggressive ultrafiltration, you also see a slight improvement in respiratory exchanges with PaO2, FiO2 ratio increasing and improving, showing that in the pathophysiology of respiratory dysfunction in the early phases may be slightly different from the pathophysiology of this disorder later on throughout the ICU stay of these patients.
So thank you, Claudio. I think for this, just to summarize what we've heard so far, it appears that a significant number of patients with COVID-19 will present with renal dysfunction at admission, and obviously that varies depending on admission practices. So in the New York study, for which Peter mentioned from Hirsch et al., about 37% of patients had AKI at admission, and the rest of them developed it during the course. The second point so far is essentially a large number of these patients will have a cardiorenal involvement associated with both a volume feature, a pressure overload, and potentially cardiomyopathy. But consequent to that is some element of right ventricular dysfunction, which would therefore manifest as more higher pulmonary artery pressures, higher CVP, and potentially renal congestion contributing to renal dysfunction. And the third point essentially is, well, could you address this with a removal of fluid at the point? But that leads me to a broader question, and first to Peter, is how do you assess volume status in a patient like the ones you've described, both at admission and also subsequently when they're on a ventilator and potentially also being placed in a prone position?
Well, I mean, what you just mentioned is a giant challenge, and we'd like to see much better technologies. But as you know, patients do get limited physical exams because they're in isolation. They many times, especially when they're prone, don't have measurement of body weight, and we're reliant on the chest X-ray and largely laboratory. So I personally think B-type natriuretic peptide can be helpful to be an indicator of cardiac volume and/or pressure overload. But we currently do not use any advanced techniques like bioimpedance or other forms of measurement of volume besides the conventional non-invasive techniques. Now, clearly, when patients need intravascular assessment of volume, they have a pulmonary capillary catheter placed and have pulmonary capillary wedge pressure measured, as well as pulmonary artery pressure, and then right atrial and right ventricle pressure when they go in. But I have to tell you, I'm dissatisfied with the overall volume assessment, and I would wager to say that the vast majority of patients after the initial resuscitative phase are globally volume overloaded.
So Peter, what's the role of cardiac echoes and also, say, lung ultrasounds or CT scans in terms of assessing volume?
Well, unfortunately, our great enthusiasm in using bedside ultrasound has really been reduced because of the contagious nature of the virus. So there are papers in press, I can tell you several at the journal Reviews in Cardiovascular Medicine, indicating some methods by which limited safe ultrasound can be done. But many hospitals like ours, unfortunately, have limited ultrasound assessment of patients who are COVID positive unless we're looking for some unexpected pathology like a pericardial effusion or pericardial tamponade. The same thing with CT. Now, it's the characteristic CT pattern of patients with COVID pneumonia, which are these spherical, large lesions in the lungs, particularly the posterior lower lungs. The characteristic appearance reported in China, we're simply not capturing in the United States because patients are not going to the CT scanner to have a CT scan. The clinical diagnosis is established, and they're largely managed clinically in these isolation units.
So, Claudio, at your institution, how do you assess volume in these patients?
Well, I must say that I have made for years a battle to have bed scales, and as you know, we do bed scales in chronic dialysis patients, and in several ICU stations, we have been able to implement the use of bed scale. So this is something that allows you at least to know differences or relative differences from admission to the ICU stay, let's say, dynamics. In some patients, we use bioimpedance. We have a portable device, but we're not using this as much as I would like. And the same is true for portable echo, although they have now implemented a system for having COVID area and non-COVID area covered by echo. Ultrasound, I think, is not useful only for comets and etc., but in general to evaluate also Doppler measurements, especially at the kidney level. I would say that in general, it's very important to get a well done daily fluid balance, which in most of the ICUs, believe me, is not done. The other thing, which is curious enough, is in those patients who are using extracorporeal ultrafiltration, while we use currently and commonly blood volume, relative blood volume changes measurement during treatment, most of the machines do not have this feature. And I think it's a waste of opportunity, because measuring intravascular refilling in these patients will be extremely important.
So just to summarize what we've heard so far is that the usual methods of volume assessment, clinical examination, point of care ultrasound, bioimpedance, or CT scans, or other imaging technology are limited largely because of the infection control issues, which therefore makes it even more relevant to manage these patients with respect to all the parameters we have. And to amplify what Claudia was saying, I think it's essential to obviously have worksheets and flow sheets which show daily fluid balance, but more importantly, to have an access to cumulative fluid balance, because the cumulative fluid balance over time is representative of some extent of what the body is seeing. Despite the inaccuracies, at least it's a parameter which can be followed. So given that that's the case, and assume that you have in whatever way or form determined that volume is a factor, what are your next steps, Peter, in terms of advising the consultants or managing these patients on your own as to when you would say, we need to get this volume off, and what tools do you have at your disposal, and how do you apply it?
I think one of the biggest determinants is the degree of need for oxygen on the mechanical ventilator, and the degree of and how feasible ventilation is for that individual patient. When we cannot sustain a partial pressure of oxygen over 60 on a blood gas, and the patient's in a desaturated state, we know that the organs are becoming hypoxemic, and then we'll have global organ dysfunction, including cardiac dysfunction. So inadequate oxygenation, I think, is a really key determinant where we just absolutely positively have to do something about volume. Now, fortunately, many of the younger patients are diuretic responsive, and they will respond to just standard use of loop diuretics. But unfortunately, in our diabetic patients, those with comorbidities, we commonly see the development of diuretic resistance, where after 1 or 2 doses of diuretics and a few hours of good urine output, that urine output drops despite the escalating use of diuretics. There's the development of azotemia, and it's fairly clear that plasma refill is being impaired. It's fairly clear there's a variety of mechanisms at play, of which the human body is not going to respond to diuretics. And in my view, that's where our critical care nephrologists can greatly help us with extracorporeal methods of volume and ultrafiltrate removal.
So Peter, before I go to Claudio, is in your experience, have you, from the cardiology side, utilized any of the extracorporeal techniques, particularly just ultrafiltration alone for managing these patients?
It's all in our center. It's controlled by nephrology. The other thing our center has done is really stratified the doctors according to age. So I have to tell you, both of you on the call are more senior to me, but it's a young person's game, if you will, in the intensive care unit. So sure, the younger nephrologists who tend to be more intensive in their approach are using a range of ultracorporeal therapies, from forms of ultrafiltration to hemodiafiltration, and then with ECMO. And we've used ECMO to VV ECMO and VA ECMO with ultrafiltration as in that whole array of extracorporeal treatment for these patients.
Okay. Claudio, your experience?
Well, I think that it's time now to start finally discussing that extracorporeal ultrafiltration can be seen as from two perspectives. One is a rescue therapy. In other words, something that you do what you cannot do anything else. And in this case, I think it's too late. And most of the time, the lack of success of this therapy in these conditions is due to the fact that we're using this in hopeless patients or in situations where everything else has failed. The other option is to use this as an elective therapy, considering the extracorporeal ultrafilter as a kind of a supplement to the physiological function of the kidney, and in fact, providing ultrafiltration at the isosmolar level in terms of removal of plasma water can really modify the response of other organs, and especially the heart, leading to a better cardio-renal interaction and restoring, in some patients, the capacity of the kidney to respond to diuretics. So I think that the studies that have been done so far are somehow flawed by the fact that they missed completely what the endpoint can be. And the groups that are compared are absolutely non-significant. I think there is a need to make better studies and to start considering extracorporeal ultrafiltration as an elective therapy, especially considering that while in the past this was considered a high-risk procedure, today there is no high risk at all. I mean, yes, you need to have a vascular access and a catheter, but almost every patient in the ICU has a catheter. And if your target is to provide a few milliliters per minute of ultrafiltration, then you don't need large blood flows, you don't need large catheters, and the risk for these patients are really limited.
So Claudio, this is, and Peter, this is both leading to a broader question, and then I will, have time, we'll leave some time for overall questions. I think the intent here is, okay, if you have patients where the fluid accumulation is a component, managing fluid becomes an important aspect of things. To build on what Claudio is saying, does it make sense to ascertain, at least in some of these patients where cardiac dysfunction is occurring or venous congestion is apparent, is rather than wait for complete deterioration of renal function that you are oliguric, is to implement a strategy of fluid management, whether it is with a diuretic alone or combination of diuretics with ultrafiltration? And if that is the case, how do you guide a clinician as to when they should consider that?
if the question is to me, in the past, we published together with Sean Bagshaw, when he was spending some sabbatical time in our own division, a kind of an algorithm that I still think is valid, and it was in fact somehow also endorsed by the Acute Disease Quality Initiative Consensus Conference that we did in London a few years ago. There is a kind of a sequential approach that you have to your patient, and your evaluation should be continuing reassessed in hours, so that you can really decide whether you want to be moving towards an extracorporeal fluid removal. In general, I don't want patients to develop a congestive status or a condition of fluid overload, although they seem to have a sufficient diuresis, because I know that this patient will easily develop AKI and develop worse outcome, because we know today that since the very beginning there is a continuum that shows that incremental positive fluid balance influence a negative outcome. This was the result of a study called Do-Re-Mi-Fa, where we analyzed the fluid overload as a factor affecting outcome.
Peter?
Yeah, I think what I've learned from Dr. Ronco is the idea is to, in at-risk patients, which is not hard to figure out, start ultrafiltration early, and that actually may make the situation more favorable for the patients to have a continued response to diuretics, and not to wait too long where they're too sick and they're too far behind on fluid balance, because these patients really don't have any margin. And in particular, if this pulmonary right ventricular failure syndrome sets in, it's too late for volume removal alone to save the patient. So I think what I've learned is that to consider ultrafiltration early, and very early in these patients, because with all this massive fluid resuscitation, that fluid has to go somewhere. And not to wait until the patient becomes completely diuretic unresponsive.
So I think what I can summarize so far is that there is an opportunity and a need for us to rethink our thought process of when fluid removal becomes important, and whether isolated fluid removal is an option in these patients. And I think that also lends itself to another consideration, is which both you and Peter, you and Claudio didn't necessarily experience this, but there was quite an experience in New York in terms of the resource constraints and on hospital strain, particularly the dialysis machines. So I think that the broader spectrum of extracorporeal therapy should include consideration of using just isolated ultrafiltration in consideration of all the other techniques. Peritoneal dialysis was utilized, and I think that's an opportunity for to be kept in mind. So I think we have a few minutes left. I'm going to stop here and see if there are questions that from the audience that we can answer. So Kelsey, any questions that you have that you'd like to pass on?
Yes, there were some questions regarding anticoagulation strategies, knowing that the patients have microthrombi as well as anticoagulation benefiting in extracorporeal therapies. How have you managed that, and what are your strategies?
Claudio?
Well, although I suggested that our chairman is the most entitled person to respond to this question, I must say that when we used unfractionated heparin, we discovered very, very soon that we needed to almost double our administration of heparin. And I'm not sure that maybe this type of policy has also saved some patients from further evolution of the hypercoagulable state and microthromby. In some patients, we used regional citrate anticoagulation with the possibility to avoid the clotting of the circuit and showing a perfect functioning of the extracorporeal circuit for hours, at least for the hours we planned the treatment. And finally, some patients receive low molecular weight heparin, and because they already received this systemically, we found no need to specifically use any anticoagulation for the extracorporeal circuit. I think that this is a situation that requires extremely personalization. Each patient has a different conditions. We have recommended some type of approach in our Lancet paper published in April, and I think these are still valid.
Peter, your thoughts?
Yeah, I personally subscribe to the idea that there probably actually is a large prothrombotic effect occurring in the lungs and the kidneys. There was an early report out of Einstein Medical Center in New York that there was a survival benefit for those chosen to receive some form of an antithrombotic. And then there were subsequent reports. And what typically happens is selection bias. So then doctors start selecting these drugs for sicker patients, and then the subsequent reports do not show a survival benefit from retrospective studies. Clearly, we need randomized trials. I think patients either need heparin intravenously at higher PTT targets or low molecular weight heparin. We've even had some outpatients using the novel anticoagulants as treatment. One of the signals for this will be a high D dimer. This has been described as well as a high CRP. So these two measures plus the characteristic syndrome may cause the doctor to think that some of the desaturation may be due to pulmonary microthrombi. And right now, because of the disease, we have no effective proven treatments. The disease is fatal in some. My view is to weigh out the risks and benefits and anticoagulate.
I think those are both very important points. In our institute, we use regional citrate anticoagulation for all our CRT techniques, and despite that, we found a group of patients who are hypercoagulable will clot their filters. And in those instances, again, they've been usually very high ferritin levels, very high D-dimer levels, and in those, by instituting a systemic anticoagulation profile, in addition to the regional citrate, we've been able to do a fairly good job of maintaining the circuits and also preventing clotting. But it is a challenge, and I think the bigger aspect here is that I think that when you're dealing with any extracorporeal circuit with requiring filtration of any kind, it's more difficult to do it with just saline flushes or no anticoagulation. So there is some need of anticoagulation itself. So Kelsey, any other questions?
Yes, there's been a request if you could expound a little bit on the cytokine storm impact overall on these patients.
If you don't mind, I quickly answer this because I have to leave 1 or 2 minutes before 4 o'clock. So in several patients, we found what we call the cytokine storm or cytokine release syndrome. And in several patients, we measured IL-6 and other cytokines, and they were significantly high. In other patients, we used clinical criteria that were basically hyperinflammation status, capillary leak syndrome, and organ dysfunction. In this situation, the use of extracorporeal therapy seems to be able to mitigate the level of the impact of cytokine, especially cutting the peaks of pro and anti-inflammatory mediators as we proposed in the peak concentration hypothesis. The results are encouraging. We have no controlled study, but still this represents an important possibility, and this was somehow reported in our published paper in blood purification. with this, I apologize, but I have to leave the meeting 2 minutes before 4 o'clock. And I thank you very much for inviting me in this wonderful webinar.
Thank you, Claudio. Really appreciate it. And thank you for staying all through the course. I really appreciate it. Thank you.
Thank you.
So, Peter, thoughts on cytokine storm?
I think the biggest task that we have now is to critically review the report released yesterday regarding the mortality benefit, a 20% mortality reduction with patients treated with dexamethasone. This was restricted to patients in the ICU and the mechanical ventilator that seemed to have a mortality benefit. But this should be hotly pursued. About a third of patients have received corticosteroids. Previously, there had been no signal that corticosteroids were associated with the benefit. And now this paper recently released just yesterday through a press release. So we'll look at that critically. Some approach to managing elevation in cytokines must be part of the future ICU care of these patients. I have a hard time believing that we're going to make any progress unless we address the immune dysregulation that this virus stimulates in the human body.
Good points. So I think we are towards the end of our time. Kelsey, any other questions that we need to address?
Yes, there is one for Dr. McCullough regarding ECMO, whether it's offered to all COVID patients in general or whether that's restricted to specific patients at a certain status due to resources.
At our center, we have a deep ECMO experience, and it's unrestricted. And our longest patient I mentioned, I think, was 45 days on ECMO. And of interest, she was very young, 22 years old, healthcare worker, and she survived after suffering many complications, bilateral pneumothoraces. She had tracheostomy, prolonged mechanical ventilation, secondary bacterial infections. But was of interest, what carried her through, in my view, is she had normal renal function all the way through, and ECMO was used for her purely for assistance in oxygenation.
Okay. Great. Thank you, Peter. And I think we're at the end of our time. So I'd like to thank you, Peter, and obviously Claudio for joining us on this webinar. Hopefully we've communicated some of the major issues which need to be tackled with respect to fluid management. And thank you to CHF Solutions for making this available and to all the audience for participating. Stay safe, stay well. Thank you very much.
Okay, and with that, we conclude today's webinar. I want to thank our panelists, Dr. Mehta, Dr. McCullough, and Dr. Ranco. I also want to thank everyone who attended the webinar. Our best wishes to you all.